Welcome back to the Deep Dive. Today we're tackling something really common, particularly for new parents or anyone revising pediatrics. Umbilical hernias in children.
That's right.
We're using the pediatric umbilical hernia notes as our source, and the aim, as always, is to pull out the absolute key info you need for quick revision.
Yep, distilling it down to the essentials. Let's get into it.
Okay, so first things first. What exactly is an umbilical hernia?
Put simply, it's when some contents from inside the abdomen, usually a bit of intestine or maybe some fatty tissue, pushes out through the umbilical ring.
The belly button, basically.
Exactly, the belly button. So you see this bulge there. It's super common in babies, infants.
And why does that happen? What's the underlying cause?
Well, the main reason is a bit of weakness in the abdominal muscles right around that umbilical ring.
Oh, okay.
That weakness means that when there's pressure inside the tummy, things can sort of bulge outwards through that spot.
Are certain babies more likely to get this?
Yes, the notes do mention a higher prevalence in infants of Afro-Caribbean descent. And there are some links, maybe associations with things like Down syndrome or certain metabolic conditions like mucopolysaccharide storage diseases.
Interesting. And beyond those associations, what are the general risk factors?
Well, being born prematurely is a big one. Low birth weight, too.
Okay.
A family history can play a role. And then, like we touched on, anything that sort of chronically increases the pressure inside the abdomen.
Like what specifically?
Things like persistent cough, maybe chronic constipation, or even conditions like ascites, which is fluid buildup. It all puts extra strain on that potentially weak spot.
So it's pressure meeting opportunity, essentially.
Yeah.
Can you explain a bit more about the pathophysiology? What's actually happening with the tissues?
So you have this defect, this weakness in the muscle layer near the belly button.
Right.
And through that gap, internal tissues, typically, intestine or fatty omentum can protrude. This forms the bulge you actually see.
And does the size vary?
Oh, yeah, definitely. They can be quite small or, larger. And importantly, you can often gently push the bulge back in. We call that reducible. If you can't, it's non-reducible or incarcerated, which is more worrying.
Okay. So if you see a bulge near the belly button, is it always an umbilical hernia, or are there other things it could be?
Good question. You do need to consider other possibilities, things like an umbilical granuloma that's like a little bit of moist pink tissue after the cord falls off, or an umbilical polyp, sometimes even a local infection. But honestly, diagnosing an umbilical hernia is usually straightforward.
So.
It's primarily a clinical diagnosis based on the physical examination, just looking and feeling.
Got it. So how common are we talking here, like in the UK?
Pretty common. The figures suggest somewhere between 10% and 30% of infants might have one.
Wow, that's quite a range, but significant.
It is. But the really key thing, the take-home message for parents and doctors, is that most of them just disappear on their own.
Oh, really? By when?
Usually by the time the child is about 3 or 4 years old. Spontaneous resolution is the norm.
That must be reassuring for parents. So what would a parent typically notice? What are the clinical signs?
The main sign is that visible bulge right at the belly button. It often looks bigger or pops out more when the baby is, say, crying, coughing, or straining during a poo.
Okay.
And then when the baby's calm or lying down flat, it might seem to vanish or get much smaller. Usually it feels soft and doesn't hurt the baby.
And investigations. You mentioned it's mostly clinical, so do we often need tests?
Not usually, no. The physical exam is almost always enough. An ultrasound is rarely needed, maybe if the diagnosis is uncertain or if it seems unusually large, or perhaps to check if it's reducible, but it's not routine.
Right. So given most resolve spontaneously, what's the usual management plan?
For the vast majority, it's simply observation, watchful waiting.
Just keep an eye on it.
Exactly. Reassure the parents, explain that it's likely to close by itself, and schedule regular follow-ups just to monitor it. Surgery isn't usually the first step.
When would surgery be considered then?
Well, if the hernia is still there after, say, age 4 or 5, or if it's particularly large, or if it starts causing symptoms like pain, and definitely if it becomes incarcerated, stuck out, and irreducible, that needs intervention.
Okay, that makes sense. And the overall outlook, the prognosis?
Generally excellent, really good.
Good.
As we said, spontaneous closure is very common, especially for the smaller ones. And even if surgery is needed down the line, it's a common, safe procedure with a very low risk of complications.
That's great news. Are there any complications parents should be aware of, even if they are rare?
Yes, though thankfully they aren't common. The main potential issues are incarceration, where the contents get trapped,
Right, you mentioned that.
and strangulation. That's the really serious one, where the blood supply to the trapped tissue gets cut off.
Ah, okay. That sounds urgent.
It is. It can lead to bowel obstruction or damage to the bowel tissue. So signs of incarceration or strangulation like sudden pain, tenderness, vomiting, or the bulge becoming hard and impossible to push back and need immediate medical attention.
Definitely crucial to know those warning signs.
Yeah.
Okay, to help remember all this, any quick tips or mnemonics?
How about thinking BURP? B for bulge at umbilicus, U for usually resolve spontaneously, R for rarely painful, and P for primarily diagnosed by physical exam.
BURP. Nice and easy. I like it. Could we run through a quick example scenario?
Sure, let's say you have a 6-month-old baby. Parents bring them in because they've noticed a soft bulge at the belly button. It seems to get bigger when the baby cries, but goes back in easily when the baby's relaxed and lying down. It doesn't seem tender. What are you thinking?
Based on everything we've said, that sounds very much like a classic umbilical hernia,
Exactly. And the key thing to remember.
most likely to resolve on its own.
Precisely.
Perfect. So summing up, umbilical hernias are common in infants, usually painless, diagnosed clinically, and the vast majority close spontaneously without needing surgery.
You've got it. That's the core message. And definitely key points for anyone prepping for the MSRA.
Absolutely. And speaking of MSRA prep, don't forget passthemsra.com and the free resources over at freemsra.com. Really useful for revision.
Definitely check those out. And maybe something for you to ponder. Considering that high rate of spontaneous closure, what specific factors really push the decision towards surgical intervention in those few cases where it is needed?
Good question to think about. Thanks for that deep dive.
My pleasure.